So tonight we're going to talk a little bit about a new device that we're rolling out. It's been in study for quite a long time, but just over the last couple of years it's become commercially available, and we've been fortunate enough to be able to develop a program here. Currently myself and Dr. Sabnani, our electrophysiologist, are doing the procedure. So far we've done about a dozen patients up at CHRISTUS, and it's been a really successful rollout for the program. I have a lot of structural and interventional heart experience, and of course Dr. Sabnani with his EP experience. The two of us do the procedures together, and it's led for a very successful rollout. So we're very fortunate in the kickoff of the program, and now we're kind of looking to expand and educate everybody about what we're able to offer. You're going to start seeing these patients in all different specialties showing up, and you'll probably have some questions about what this is and who needs this, and so that's what we're going to talk a little bit about today. If anybody has any questions throughout the presentation, just jump in there. So atrial fibrillation is really a growing disease. By the year 2050, it's expected to over double in incidence. If you have AFib, you're at a 5-fold risk for stroke. Of the strokes that come into the hospital, 1 in 5 of those people will have AFib. And almost half of the people experiencing a stroke will suffer a second stroke within 6 months of their initial diagnosis, which is pretty devastating, knowing already what the mortality rate is with a single stroke. What is thought to be 90% of the problem for AFib and the stroke development is the left atrial appendage. It's like our appendix. It doesn't serve any purpose but to cause problems. We get thrombus formation there, mainly from stasis when people are in AFib. So when people are in AFib, the top chamber of the heart is just kind of quivering. It's not gushing. The appendage also pumps usually whenever it's in sinus, and whenever it's quivering, blood will pool there. Pooling blood likes to turn into clots. And when people go back into the normal rhythm, it can come out and cause a devastating stroke. And these thrombus can be quite large, and so the stroke can be quite a bit larger than some of the smaller ischemic strokes we see. Current recommendations for treatment of atrial fibrillation, usually it revolves around assigning a stroke risk. So people that are low risk, we may assign to no anticoagulation or aspirin therapy. As you get up to a higher risk score determined by a scoring system we call the CHADS score, or CHADS VAS score is a more comprehensive score that most of us are using these days. We start recommending oral anticoagulation. Historically, everybody remembers we were only using Coumadin. Nowadays, I'm sure everybody's familiar with the new oral anticoagulants, and most people that we have outside of valvular heart disease are on these agents. Despite the need for oral anticoagulation and the risk these people have, the overall usage hasn't really improved much. We're still really peaking at about 50% use for patients that are at need for this disease, and interestingly, the people that are at higher risk start getting a decline in the usage of this medication. So really the people that are at the highest risk for stroke in the setting of AFib are starting to get less and less therapy for it, probably because they have other chronic conditions which may be contraindication for the anticoagulation. Another big problem is people just don't want to take it. A lot of people don't want to be on blood thinners to begin with, and then you put them on it, they agree to take it in the office, and they go home and you're writing the script and doing a good job, but they're not taking it. So up to 30% of patients stop taking the drug at 2 years. So even the people of that 50%, a third of those were dropping out because they're just not taking it. They decided to come off of it for whatever reason, whether they have a bleeding event, their cousin has one, or they just think it's a bad idea. Or even with these novel, oral anticoagulants, I get, time after time, I'm sure you hear these people complain about the cost. And so for a lot of these people, it's just cost prohibitive. They get a bill for $300 a month, especially if they're in their donut for their Medicare, and they just can't afford it. It becomes prohibitive for them. And a lot of them are embarrassed to bring that up in the office to say, I can't afford this. They just won't fill the prescription or tell you. They'll just say they're taking it. So of course that leads to the next discussion is, people want to come up with an alternative to anticoagulation. Is there a way that we can get around putting everybody on blood thinners, or what about the people that aren't good candidates for blood thinners? And so they started developing ways to close off or get rid of the left atrial appendage. Of course, you can do a surgical ligation, which is an open procedure. It's kind of a big procedure to get rid of the appendage. There was another device where you go in, kind of access the pericardium surgically and put a snare around the left atrial appendage, kind of a minimally invasive approach. But this is the first device that has really made it to the finish line as far as being able to be in commercial production. And it's called the Watchman device, and it's made by Boston Scientific. And it looks just like this. In fact, we have a little model. If y'all want to see one, we can pass it around to show you what the device. There's a kind of a cartoon model, and then there's an actual device that's with it. It looks like a little, I don't know, Portuguese man-o'-war or jellyfish. It's kind of, whenever we get the thing, it's in a catheter, so it's loaded in a catheter. It's crumped down like an umbrella. We put the catheter in the appendage, and when it pops open, it looks like this. It's got this covered kind of mesh surface area, which occludes the ostium of the appendage, and this gets endothelialized and covered over, and after a while it looks just like regular heart tissue, and it essentially excludes the appendage, so there's no area for thrombus to form and come out. So currently the indications for this device are people that are increased risk for stroke, that have been deemed to be suitable for anticoagulation, at least for short term, and have an appropriate rationale to seek a non-pharmacologic alternative. So, and it's really, I know it sounds vague, but it really is vague. So that's what the FDA approval is. They don't have to be not candidates for anticoagulation, meaning they don't have to be someone that's had 5 bleeds and now you're ready to give up. They can be people that can afford it. They can be people that just don't want to take it, that have high-risk occupations. And then, of course, the people that are at fall risk and at high risk for bleeding. As far as the data, we'll just run through some of this. I'm not going to go into all the trials in depth. I want to kind of hit the highlights of the data. It's really one of the more studied devices I've ever seen before the rollout of the device. It was studied. I remember being a fellow, 10 years ago and hearing about this device, like, oh, it's coming. And it seemed like every year went by and we knew that it was coming, it's coming, and it just never came. It's because they studied it for so long and the FDA made them go back and do additional studies. So there's actually been thousands of patients studied before this ever rolled out to be commercially available. So our implantation success right now is running at about 95%, and that's just defined as being able to deploy the device and have a success at the time and seal of the appendage. It's effective. It has as far as stroke is concerned, there's actually even an advantage over warfarin for fatal or disabling stroke, and we'll show that in a later slide, that in the early studies there was even favorable towards all-cause mortality towards the Watchman over anticoagulation, and that probably has to do not so much just with the stroke, but just with the other things that go along with being on blood thinners. There's several major studies. The PROTECT and the PREVAIL were the randomized trials that really got this device to commercial approval, along with 2 major registry studies. And this is just the sum data from those. And so anything on the left is favoring Watchman, anything on the right is favoring warfarin. This was studied with warfarin, so I know all y'all are probably saying, well, what about NOACs? And they are studying that, so we'll have that data coming out in the next few years. But we don't have that yet. Back whenever this device started, because that's actually demonstrates how old this thing has been around. It was because they didn't have the NOACs back then. They started with only Coumadin, and that's where they started their approval process with as the standard of care. For all stroke, you can see that it's relatively equal for both devices. For hemorrhagic stroke, as would be expected, not being on anticoagulation, you're going to have less hemorrhagic stroke. And this is what I mentioned, all-cause death was actually skewed towards the Watchman, as well as, of course, a major reduction in bleeding compared to people that are on Coumadin therapy. This is the safety profile. This is the PROTECT study, which is the initial study that came out. And even among the PROTECT study, there was like an early data set and a late data set, and it had to do with the learning curve with deploying this device. There were some issues with tamponade initially with how they were positioning the catheter and occasionally perforating the left atrial appendage, which they were able to correct with an addition to the procedure, as well as device embolization, which they've also improved with different sizing criteria and release criteria. So from the initial study here down to where we are today, which is real-world data, you can see that the complication rate is slowly downtrended, and now it's a very rare incidence of tamponade. Procedure-related stroke is very low now because of de-airing and other things we do to prevent intraprocedural stroke. And it's very rare that the device will embolize. That was one of the other concerns, and what people have is what if the thing gets loose and then it just ends up tumbling down somewhere. And so fortunately, those things occur very rarely these days. So as a comparison to other cardiac procedures we do, this is a very safe procedure for our patients. And this is just another slide demonstrating the data going through the PROTECT trial, which was the initial study, the PREVAIL, and then these two CAP studies are the registries, and then this is more of a real-world data registry study. And you can see initially there's a procedure-related stroke of up to 1.1%, and now that's down to post-FDA approval 0.08%. So it's a very low incidence of stroke. Device embolization is down to 0.2% in the post-FDA approval era. And that just goes back to that. I think there was some initial concern about the device, but as we've learned how to deploy it, those have gotten a lot better. So I think patient safety concerns, we can put those to rest pretty easily. So who's eligible for this device? According to the FDA and Medicare, the patient has to have a CHADS VAS score of 3 or greater or a CHADS score of 2 or greater. They have to be suitable for short-term warfarin, but deemed unable or poor candidates for long-term therapy. And this again gets back to that other slide that I talked about. Whatever reason that you or the patient come up with that the patient is not a good candidate for long-term anticoagulation is acceptable. And then the other thing that Medicare threw in that this doesn't apply to commercial pay patients, this is specific to Medicare, is they have to have documented evidence of a formal shared decision-making interaction between the patient and a non-implanting physician. So in our group, anybody other than myself or Dr. Subnani qualifies as that. But as we move forward, primary care physicians, GI docs, whoever sees the patient and knows enough about the Watchman to discuss it with them will qualify as this role. And in a lot of centers, the hospitalist or whoever refers the patient to the interventionalist will document that they participated in a shared decision-making program. We actually have it on our referral sheet where you can just check that you've discussed it with the patient. It's kind of this creates a lot of confusion. It created a lot of confusion with our group initially because people were looking for this tool online to go, that they thought they had to go through this with the patient. These tools, they're not for going through information in a clinic setting. They're just knowledge bases. So if you know anything about atrial fibrillation and the appropriateness for blood thinners, then you know enough to participate in a shared decision making. Those are all the tools go over. They just are websites that talk about AFib, the risk of stroke, and the benefit of anticoagulation. And so it's not something that you have to use with every patient. It's just something that you have to say that you're using that knowledge bank, which is the same knowledge that everybody has about atrial fibrillation, who's able to talk about atrial fibrillation or blood thinners with their patients. So, but we have to put this statement in somewhere along the way that says that they talked to somebody who's not the implanting physician and they thought it was a good idea. We also have to enroll them in a registry, so we have a left atrial appendage registry at the hospital now with all of our device implants. Operator requirements, you have to have an interventional cardiologist or an electrophysiologist, and any one of the implanting physicians must have performed at least 25 transeptal punctures, and the facility requirements must be in a hospital with either an established structural heart program or electrophysiology program. So this is a device. It comes in all different sizes to fit different sizes of appendages. We do screen the appendage before we get in there because there is a 2% on the bell curve. There's 2% of people that fall out. Their appendage is too small for the smallest device, or it's too large for the largest device. But 98% of people basically will qualify for this device. It has this nitinol frame, which is very forgiving. It's got these little anchors on the feet which anchor it into the appendage after we deploy it, and this is the surface that gets endothelialized. And here's kind of a picture. We have to go we actually start off from the right side, the venous side. We go up to the right atrium. We puncture across the septum with a catheter, and we deploy the thing right at the ostium of the left atrial appendage. It's a general anesthesia procedure, at least for now. I think foreseeably it may not be in the future. It says 1 hour. Our time is around 30 minutes at this point for doing these, and it could probably even be a little bit quicker. It is mandated as an overnight stay, so we do admit these patients as an inpatient overnight. That's even something I think if we get off of the general anesthesia, they may be going home the same day in the future. And this is just a little, I don't know if you can see these with the echo and the lights in here, but this is just a kind of a picture of what it looks like. Usually there's like a little cone-shaped structure here called the appendage, and this is just the device sealing it off. And this is just a better animation of it, drawing of it, sitting at the ostium of the appendage. You can see the little feet. They kind of dig into all these trabecula that are in the appendage and anchor it into place. Here's a good slide. This is an actual Watchman patient. He didn't die from the Watchman. I think he was in a motor vehicle accident, but they took an image at autopsy of what the Watchman looks like. It's a canine model. You can kind of see the device there becoming endothelialized, and then at 45 days, it's pretty much sealed off. And this is 9 months post-implant on a patient. And really the only part that's distinguishable from the other surface of the atrium, you can see the little screw area where the device was detached, the little metal ferrule there. So the implant procedure, so prior to implantation, we start them on aspirin. And at 45 days, and then we also initiate them on anticoagulation if they're not on anticoagulation. We will usually continue whatever they're on up through the procedure time, so we don't stop the Coumadin or the Eliquis or whatever they're on when we bring them in. We'll do the procedure. It's pretty low bleeding risk because we're going through a vein. If it was an arterial study, we'd probably have to stop the anticoagulation and do some type of bridge or other therapy. But since it's a venous study, the risk for bleeding is pretty low, so we're able to keep them on anticoagulation. At 45 days post-implant, we do a TEE. And if the thing is sealed up, then when they're able to come off the anticoagulation, they go on to Plavix plus aspirin for 6 months post-implant. And then at that time, they reduce down to just aspirin alone. And we do a 1-year follow-up TE as well. Overall, at 45 days, 92% of the patients are able to discontinue anticoagulation. The reason that they're not able to discontinue anticoagulation is if they have a leak around the device. And that's defined as over 5 millimeters. So 5 millimeters or less, we can stop the anticoagulation. If it's more than 5 millimeters, we have to keep it going and reassess them at a year. At a year's time, 99% of them can come off. And we don't have to wait the full year. If they still have a leak at 45 days, we may bring them back at 3-4 months, whatever seems reasonable, and look again to try to get them off as soon as possible. So overall take-homes that, as far as deploying the device, it's fairly easy to deploy. There's a very high success rate. We're able to get a device in over 95% of patients who qualify for the procedure. It's a fairly low complication rate. At a year's time, we can get almost 99% of people off of anticoagulation. At least with the earlier studies, there's a suggestion that there's a reduced risk of disabling or fatal strokes with the Watchman device compared to Coumadin. Anticoagulation, I will say, is still slightly favorable over the Watchman device for embolic type of strokes. So I always counsel patients on that. It's not a better procedure. It's not better than taking oral anticoagulation for preventing embolic strokes from the AFib. But with these other factors added in, the overall benefit may be in favor of the Watchman device. As far as the flow for getting these patients into the system, you can refer them to Dr. Subnani or myself directly if they're not already seeing our group. If they have other cardiac issues and need to see their group, they can go through that process, and one of them can do the shared decision making and send them over for us for the Watchman after they work up whatever else is going on with their AFib. Most of the patients with AFib are probably seeing one of our cardiologists, general guys in the group. But if sometimes the patient goes into a hospital, has a bleed, and we'll see y'all before they come back to see their cardiologist, or you may be seeing them for some other issue that is related to their bleeding. And if you think that they're not a good candidate to be on anticoagulation and would like them to be evaluated, we're happy to see them in our clinic. We'll usually get a TE to evaluate to rule out that that their appendage is suitable for the device, that it's not too big or too small. The majority of the patients that we're seeing for AFib have had a TE at some point in their life. And some of those that have been on anticoagulation, because the risk is so low, we can even offer to do the TE on the day of the procedure just before we take them back. And then one of us will see them, either myself or Dr. Savnani, and counsel them on the procedure and get them scheduled. We'll see them 1 to 2 weeks afterwards just to see how they're doing after the procedure, and then we'll do the 45-day follow-up TE, which is the one that they all look forward to. And I did 3 of them on Monday and took 3 people off anticoagulation, and they were all super happy. And so you might be starting to see some of these people back in the clinic, and I suspect with the primary cares and GI especially, and some of these other groups that deal with people that have bleeds, you are going to be pretty happy to see some of these patients back off anticoagulation.